So I'll be speaking about common disorders of pain in primary care. I have no conflict of interest, and I will discuss off-label medication uses, as is often the case. And I don't think the slide set includes the other disclosures that this is funded by the COPE REMS. It's not printed here, but it is also funded by the COPE REMS FDA-required training opportunities, as well as an NIH R01 that many of you have been participants in this study. So that's no conflict, but just is supporting us here. My objectives today will be to know the characteristics of commonly managed primary care pain disorders, be familiar with the non-drug treatment options for these that are encountered in primary care practice, and then be able to introduce effective pharmacological treatment approaches to these disorders. So interesting, probably in the background slide of our group, you can see on the whiteboard behind me was a chat we had last night here in the Center for Pain Relief. We have a regular Tuesday evening conference, which, by the way, is open to the public or anyone willing to brave Seattle traffic at 5 o'clock in the afternoon to get here and leave when traffic is still ongoing at 6. But the discussion was, what are the common chronic pain disorders? And we had our incoming pain fellows participate in that. And you could see the list actually includes these above. And I was silent during that discussion, but my own 27 years doing predominantly primary care, these were the disorders that I saw. And we're going to cover these in the course of the discussion. Spinal pain syndromes, musculoskeletal pain syndromes, headache disorder, neuropathic pain, and then abdominal and pelvic pain syndromes, or broadly speaking, visceral pain syndromes, and then regional and widespread pain syndromes. So, speaking to spinal pain, we can look at cervicalgia, which means a pain in the neck. Neck hurts, very commonly seen in primary care settings, and chronic low back pain disorders. Again, these can be acute, but they become problematic in the primary care setting when they are chronic. There's a term out there called discogenic pain. It's an interesting term, and we could have a big debate here. I'm sure Dr. Robbins would be happy to provide his input on what discogenic pain is. I say discogenic pain means we're not sure, but we think it has something to do with the disc. We do not understand the mechanisms of discogenic pain. We also have to remember that all people who are in an upright posture, exposed to a gravitational field as strong as the Earth's, will develop changes in their spine because we are bipedal. So changes that appear on MRI that often have disc become what are called degenerative disc disease. It's a terrible term because degenerative suggests that that's a pathological process. And instead it is just a natural phenomenon associated with being upright in a gravitational field. But oftentimes pain is attributed to this process, and a combination of discogenic and degenerative often leads to many unnecessary spine surgeries. So this is a very regular appearing problem and a source of many future chronic pain patients. So it's an area that is very important that primary care providers understand and recognize. And then if we get out of the hard structures, the discs and bones, facet and bony vertebrae, we get into the soft tissue or myofascial features of pain. And here it reflects pain that we believe is arising from the muscular structures, and even more importantly from the fascia, which are the pain-innervated structures that support the neck and back. We should remember that muscles themselves in the meat of the muscle have no pain fiber. For instance, when we poke our patients to give them an intramuscular injection for their detect protocols or whatever intramuscular, it hurts when it penetrates the fascia and does not hurt in the muscle. So it's predominantly the fascial structures that are painful and contributes to less than clear pain syndromes, but are very, very commonly occurring. Radiculopathy, or radicular pain, to be precise. Radiculopathy specifically refers to pain that we attribute to spinal root involvement following a radicular pathway that is known as a dermatome. So if it's specific to a dermatome, is painful and it's attributed to a spinal root involvement, that is called radiculopathy. If it is dermatomal and not associated with spinal root involvement, we call that radicular, because the apathy per se is not found, the root is not involved, and that's a radicular pain. Again, this is naming, but also suggests how we might treat it and how we might convey and communicate this information to our patients. And then thirdly, this is not, I assure you, is not part of the DSM, the ICD-10 criteria. So we don't have an ICD-10 code for failed back surgery syndrome, but this simply refers to a widely used construct of someone who's been through typically 2 spine surgeries and pain persists. It can be present with or without radicular pain. It is not a radiculopathy, because that means the pin needs to be, the screws need to be moved, hardware needs to be adjusted, or the fusion has failed and is now impinging upon nervous structure. But if there's no clear-cut impingement, we would call this failed back surgery syndrome. This is the classic, the surgery's gorgeous, the x-rays are perfect. Why don't you go back to your primary care provider, because I don't know what to do with your pain. And these are the cases as we see them in our office after having had the spine surgery. So some common themes I've alluded to already. Imaging is often not helpful. There's clear guidelines now for when we obtain imaging. These are extremely reasonable, and imaging often identifies incidentalomas, which we chase. These are incidental findings that create pathology in the patient's minds, fear in the uninformed clinician, and unnecessary surgery. And I actually finally got around to reading Atul Gawande's recent New Yorker piece on medical waste, and he had a nice discussion. If you haven't read it, he writes enviously beautifully, very well informed, and it was about a month or so, I think, one of the May issues. If you can get a hold of that, it'll warm your heart to realize that you're not the only one who's experiencing this. It's a real national problem. The radiculopathy needs to be dermatomal, as I mentioned, or else it's just purely radicular pain. There may or may not be nociceptive component. So in other words, the tissue may not be actively injured to the degree that we would expect nociceptive input. So this is where the appearance on the image shows maybe a nerve being abutted by a facet that's involved in arthritic changes. Hardware is not touching anything. The disc bulge is just a bulge. It's just a protrusion, but it's not actually abutting the nerve root and producing what we'd expect nociceptive component. And this fits into the model of sensitization and the central sensitization pathways, for which we do not really understand at this point how these and why these occur. All sorts of theories that abound. The current hot topic at the American Pain Society meetings was that this is a glial cell mediated event from activation of glial cells that remain activated, that are giving the alarm to the central nervous system, because they're the macrophages of the central nervous system telling the central nervous system that there's some trouble afoot, but they are inappropriately activated. I should make a note to you all that one way to activate these central sensitization mechanisms is to apply opioids, because opioids activate glial cells. And interesting, naltrexone orally or naloxone in intravenous models will stop glial cell activation, which is new work that stay tuned to, you'll learn about, because we're learning now about how they may be more involved and how opioids may actually be a problem in these cases. Again, a common theme is getting your patients back to activity and re-engagement in life to achieve quality of life. We'll manage their pain, so we have to overcome fear of pain, avoidance of use, and the general deconditioning phenomenon. We also need to avoid treatments that reduce energy and reduce motivation, and this is opioids and benzos, and typically useless muscle relaxants that have no evidence of effect and benefit in long-term exposure. And again, chronic opioids, especially at high dose, may, and in fact, this slide needs to be updated, do contribute to worse outcomes based on recent NIH review of all this subject. So in primary care, the spine pain treatments, non-pharmacological, we'll start with. Exercise, structured rehab. Dr. Robinson continues to give regular didactics on that. If the patient can stand and walk, physical therapy. If they're in such bad shape that the best they can do is float in pools or walk against water resistance, that's excellent. So aquatic and land-based physical therapy. Cognitive behavioral therapy continues to be the mainstay, which is to reduce catastrophizing, calming of the patient, goal setting, and effectively brain retrain the behaviors that are associated with these negative thoughts about what this pain might mean for the patient. Sleep hygiene. Get to sleep more than 5 hours, your pain will be 50% less severe. Dietary hygiene, reduce inflammatory triggers. Dr. Tick speaks often about inflammatory diets. We know that obesity is not a good thing for back pain. Roles of hypnotherapy, acupuncture, and the like. Medications, if there's active nociceptive pain, NSAIDs, highly appropriate. Steroids when it's inflammatory, and this can be get provided orally and rapidly tapered. A Medrol dose pack, that's 24 milligrams, rapid taper down, may help. Often that's about half as much as you need. Be cautious on oral steroids based on the known side effects, but we're talking a short course. This may get your patient past a acute disc, radicular pain, oral taper of corticosteroids, prednisone, perhaps at 40 milligrams, rapidly taper, may reduce enough local neural structure edema and clear the radiculopathy. Early on, persistent pain, clear radiculopathy, this is a very appropriate referral to a pain specialist for an image-guided intervention. We know that epidurals for spinal stenosis without leg pain, without impingement, are not effective. I and many others feel, based on clinical experience, that transforaminal epidurals will play a very significant role in management of patients. This study actually is a national study. It's just going to be launched, so we're going to get some quality prospective study. And actually, University of Washington is one of the centers, and Dr. Brett Stacy, our medical director here, is the site, the lead on this study. So we'll be learning about how effective these are in properly screened patients. Tricyclic antidepressants and SNRIs, excellent. Help for sleep, help for mood, and our analgesics. Anti-epileptic drugs, predominantly the gabapentinoids, so that's gabapentin and pregabalin, otherwise known as Lyrica, can be very effective as well. And in exceptional cases, only if the patient is able to engage in the structured rehab might these be considered. Going above 100 MED, I put 120 here, probably going above 50 based on current evidence is likely to produce more impairment than benefit. It's still quite controversial. Non-spinal musculoskeletal diseases include osteoarthritis, post-traumatic arthritis, inflammatory arthritis, and tendinitis from overuse or from inflammation, and sometimes we don't even know what's causing this persistent tendon pain, and this fits in the term called enthesopathies, which is tough if you have a lisp. It's hard for me to say, but this refers to a tendon that's producing pain, remains in the tendon, and we do not identify a particular structural or inflammatory process present. Again, osteoarthritis is a normal aging process. It does not hurt, and it certainly should not be something that leads a patient to become profoundly disabled, and particularly on high-dose polypharmacy. The structural deformity will contribute to the mechanical abnormalities that, if they're not addressed, may increase pain and limitations. Obesity and deconditioning will need to be addressed in all these subtypes I've described. There may be an inflammatory component. If there is not, using anti-inflammatory drugs is not only useless, but has a risk of complications of anti-inflammatories. And I would note that anti-inflammatories are the most common drug reported adverse effect in the world in terms of side effects, partly because they're so available and over the counter, but also they're being used for circumstances that they're really more hazardous than beneficial. Return to activity is crucial, both for quality of life and to manage pain. Same conversation I had for spinal pain. We need to overcome fear of pain, which is kinesiophobia, which leads to patients not using their limbs and subsequent deconditioning. And again, avoid treatments that reduce energy motivation. And again, opioids, particularly high dose, contribute to worse outcomes. Some specific treatments, for the sake of time, I'm going to run through them. You have this as a PDF available to you. Osteoarthritis, acetaminophen may help. NSAIDs work a bit better. Opioids may work better yet. But again, we run into the problems with chronicity and perhaps increasing central pain syndromes in response to chronic opiate exposures. So I've listed here intermittent and low dose, and again, focused on allowing patients to hit a focused activity or a rehabilitation setting. In acute and subacute trauma, again, NSAIDs, ice heat, immobilization only as required for the protection of the joint, but rapid remobilization, the most effective preventive treatment for CRPS, otherwise known as RSD, is rapid mobilization. Muscle relaxants, perhaps acutely. This would include the non-benzodiazepine and the non-antispasticity drugs. That's baclofen and tizanidine. There's not clear evidence that they play a role in acute, subacute trauma. Cyclobenzaprine, remember, is a tricyclic antidepressant agent that has no antidepressant effects. So I quote Dr. Sullivan, it's a tricyclic non-antidepressant drug, but be cautious about it if a patient is on other antidepressant drugs. It is also a QT prolonger, so if they're on methadone, you're going to run into potential risks of cardiac arrhythmias, just willy-nilly tossing cyclobenzaprine or Flexeril around. Rarely opioids. For inflammatory arthritis, real role for NSAIDs, real role for disease-modifying anti-rheumatic drugs or DMARDs. Unless you have particular expertise in this, this is where I will frequently get support from a rheumatologist. Steroids, when indicated, clearly physical therapy and occupational therapy or both would be useful. And again, rare opioids, moderate dose. A few words on headache. Extraordinarily common. You know, the incidence is 17 to 20% regular migraine episodes based on some studies in primary care practices is extraordinarily common. And many of these patients who start with migraine devolve into chronic daily headaches, which is a consequence of prescribing drugs that sensitize the brain. And that includes opioids, benzos, acetaminophen has been listed as a rebounding drug, and even regular use of the triptans can produce what's now called chronic daily headache. Migraine is defined by its periodicity, in part, so a headache that's occurring every single day is not a migraine, and it should be treated as a chronic disorder rather than a periodic or episodic pain disorder. Excuse me. Then musculoskeletal headaches can come from the jaw, temporomandibular disorders. TMD is also one of the central sensitization syndromes. So this may represent just general increase in noxious experience from non-noxious stimuli. Cervicogenic headaches arising from the neck muscles. This would be a myofascial characteristic, or tension headaches as well. Excuse me a second. So just a word about the pathology and anatomy of headaches. Let me get the mouse here. So the trigeminal nerve is activated by the structures that we think trigger migraine headache. Periaqueductal gray structures may be the source of the electrical discharge in the brain that then follows this pathway up to the trigeminal nerve, which is why the trigeminal nerve then proceeds to innervate the meninges and the vascular structures. So the current theory of why headaches of all types appear to be vascular is because the dural vessels are innervated by that trigeminal nerve, and it's probably induced, and this is where we use the triptans, is to chill out the serotonergic nerves that are firing in the PAG that then follow this pathway to the vascular structures and as well to the meningeal structures. Common themes. First off, headaches are very common. They are rarely cause for alarm. Red flags listed: sudden, explosive, associated with fever, meningeal signs, headache associated with mental status change, headaches that awaken patients from sleep, headaches associated with syncope or vertigo. Patients with headache can have an abnormal neurologic exam. Headaches that are associated with a very significant blood pressure increase. Again, the blood pressure increase may be related to anxiety from the headache, but we're talking about diastolics over 108, 110 represent a medical red flag. And don't forget to palpate the temporal artery. That may be a cause of temporal arteritis for the headache. Routine analgesic medications promote and perpetuate headaches. Very commonly, the socio and psychological factors exceed the biological or the biomedical cause for headaches. And as I've mentioned at previous sessions here, sometimes the treatment for chronic daily headache and even migraine headache is a spousectomy, because often exploring what's going on in the household and improving home situation, family matters is the solution. And we tend to go to the biomedical because that's quick and easy rather than the messy challenge of helping people restructure their lives. Preventative therapies are crucial. Diet, sleep, hygiene, fitness, and pharmacologic, particularly when there's a recurrent migraine, but these others are going to be driven by non-pharmacological techniques. So avoid triggers. Biofeedback and relaxation, critically important. There's evidence to support magnesium, feverfew, and riboflavin for managing headaches. These are available in some compounded over-the-counter products. The riboflavin dose is 400 milligrams a day. The magnesium is titrate to loose bowels. And feverfew, I do not remember the dose. I apologize, but this is available, and there is some evidence-based support for these singly or in combination as a preventative measure. Triptans or dihydroergotamine, that's Migranol, ergot, for less than 10 a month. If you're getting more than 10 a month, you've got to add a preventative treatment, which include beta blockers, anticonvulsant drugs, antidepressants, all kinds, even SSRIs are helpful for managing migraine, and particularly when there's depression or anxiety. And for persistent temporomandibular disease, oral appliances may be useful. Oral medicine consultation may be useful. And again, TMD may be part of a central sensitization syndrome if it's co-occurring with fibromyalgia, post-traumatic stress disorder, irritable bowel, interstitial cystitis, that constellation of syndromes that focus us on central pain mechanisms. Neuropathic pain, primary care presentations, peripheral neuropathy, very common, metabolic causes, entrapment, such as carpal tunnel, or post-infectious, that would be associated with shingles or herpes or HIV disease, and Lyme disease as a spirochetal cause of peripheral neuropathy, and post-chemotherapy for cancer patients and cancer survivor patients, a difficult pain management problem in general, and then nerve diseases of the face, particularly trigeminal neuralgia, less common, but may be presenting and often confuses us because it looks a little like TMD or temporomandibular disease as well. Again, common themes are identifying the cause, diabetes, B12 deficiency, thyroid disease, autoimmune disease, and entrapments. All too often, peripheral neuropathies turn out to be idiopathic, but you got to do the workup before you say it's idiopathic. And some of these disorders, even after addressing the cause, may not relieve the neuropathic symptoms. And that patients may be disappointed by the fact there may be enough damage that the nerve was never going to respond normally. We do know that after a peripheral nerve is damaged, it often never recovers its previous intact function. The damage may persist predominantly on the sensory side. Don't forget, all the medicines we use for neuropathic pain are at best 30% reduction in pain intensity. So our goal is to improve quality of life and manage pain. And this is the same words I put in the past slide. Very easy. Overcome fear of pain, avoid treatments that reduce energy, get people back in the game, and avoid opioids, especially chronic and high outcomes. The medications that are recommended for management of neuropathic pain include the most effective based on numbers needed to treat, the tricyclics, tricky drugs sometimes, but they still remain best evidence-based support. SNRIs, i.e. duloxetine, the numbers needed to treat are a little less satisfactory compared to TCAs. And then the anti-epileptic or anticonvulsant drugs, the calcium blockers like gabapentin or pregabalin, and or the sodium channel blockers that we would see with Tegretol, Trileptal may be useful. Topical lidocaine, topical capsaicin, vitamin supplements when deficiency is present to replace. There's some evidence that patients report reduction in pain with extra supplement B12. That's not clear that it's managing the actual biomedical problem, but is not unreasonable if it gets your patient back in the game. Opiates low dose when all else fails and benefits are sustained, and the patient's a suitable candidate for opiates for refractory neuropathic pain. Opiates are about as effective as the other drugs, but have the problems of chronification with chronic use and all the other difficulties we encounter. Chronic abdominal pain syndromes, irritable bowel syndrome, inflammatory bowel, endometriosis, interstitial cystitis, and prostatitis, regular issues. Again, common themes, make the diagnosis if possible. If the patient has chronic abdominal pain without obstructive events, current evidence base recommends against adhesiolysis or treating adhesions unless there is evidence of obstruction. Best guidelines right now for post-pelvic pain surgeries, cutting more without evidence of obstruction does not lead to improved outcomes. Over time, visceral hyperalgesia, excess pain from the gut, is a central sensitization phenomenon, and hence chronic opiates complicate the outcomes. I have taken the liberty of creating a new name disorder, opiate-induced visceral hyperalgesia, commonly seen in chronic pelvic pain and interstitial cystitis. Chronic episodic pain can promote dose escalation, so in other words, pushing that system with periodic pain increases like we might see in inflammatory bowel disease, i.e. Crohn's disease, make it challenging because this increases nociceptive input and winds up the central phenomenon. Social and psychological factors continue to contribute as always, and a flare management plan is critical in episodic recurring disease. This isn't not flare management, I take meds and I go to bed. This is how do I, using cognitive behavioral strategies and other self-management techniques, prevent the intake of these drugs that will lead to further sensitization. So in terms of treatments, irritable bowel syndrome, best outcomes published at this point, cognitive behavioral therapy, diet, and sleep hygiene. This is nothing out of a pill bottle. This is, again, self-management techniques. Tricyclic antidepressants are as evidence-based as the straight-out anticholinergics. The advantage of the tricyclics is that they are analgesics in addition to anticholinergic, and if the patient's depressed and anxious about their syndrome, it will also help. Opioids have frequent adverse drug events, promote visceral hyperalgesia, are absolutely to be avoided, and are associated also with constipation and other further exacerbations of the underlying syndrome. Interstitial cystitis, managed like chronic pelvic pain syndromes. If it's infectious, treat it. If it's related to dysmenorrhea, NSAIDs, acetaminophen, oral contraceptives. Endometriosis that is not surgically responsive, danazole, Depo-Provera, and letrozole. Maybe evidence at this point is building, but it isn't yet solid evidence-based support. Treat the PTSD, which is commonly co-occurring. First, identify it. Primary and secondary mood orders are necessary to treat, and multidisciplinary treatment, CBT, PT, the updated published urological guidelines for managing both interstitial cystitis and chronic pelvic pain are multidisciplinary pain management, including CBT, activation, gabapentinoids and tricyclics or SNRIs. That's best evidence-based treatment for these syndromes. Again, we're seeing a recurring theme. We don't have enough medicines that work that well, so we're using the same ones, but they still are supported by evidence-based support. TCAs, SNRIs, very significant PTSD or anxiety that's difficult to manage, SSRIs, and again, the anti-epileptic drugs. Fibromyalgia, widespread pain disorders, and myofascial pain disorders. Again, same story, same meds, and if there's myofascial features that it's just associated with a single muscle, we're performing intramuscular stimulation, Dr. Tick and Dr. Rapp in our clinic, trigger point injections, and then physical therapy that's focused on improving the underlying mechanics that's contributing to the myofascial pain. So conclusions. All chronic pain is complex even if you get a simple diagnosis. The life experience matters. With persistence, central sensitization occurs, frequent co-occurring conditions, and risks and side effects of our treatments need to be paid attention to. The pain type needs to be understood. Is there nociception? Is this predominantly neuropathic, or is it, as often seen, mixed? Follow your outcomes, and don't forget that medication benefits are at best 30, maybe rarely 50%, so we need much more than medications. So thanks for your attention. I think we can move forward here. Catherine Henderson, what form of magnesium is covered by Medicaid? I have no idea. Does anyone know out there? Anyone else managing patients can chime in? Send us a Adobe signal. I do not know. Magnesium citrate is often recommended. I think you're going to have to be careful about what you label the diagnosis. It's not terribly expensive as a drug to be used. Dr. Tick would probably know the answer.
She recommends glycinate and citrate, but I don't know. She says you have to go to a natural food store to get them, so that sounds like they may not be covered.
Yes. So magnesium is available as 400 or 800 milligram in the citrate form. It's not nearly as costly as the other prescription drugs we give, so not to blow that off. Deborah Dobbs, thank you, Deborah. Trimeme Epsom salts are cheap. 4 to 6 cups in the bath. So this is something also that Dr. Tick has recommended, and is nothing like a soothing bath to relax the system as well and let all our treatments work. Plus, the Epsom salt, they're not designed to be taken orally, so that's another option to increase magnesium exposure. But there's interesting support for magnesium in a lot of myofascial pain disorders. Again, they're not long-term randomized trials, but there is evidence-based support for their use.